All right. Well, welcome everyone to our first session of 2024. I'll go ahead and share my screen. As I'm doing so, I'll also introduce myself. I'm Chris Rhodes. I'm a neuropsychologist here at Memory and Brain Wellness at University of Washington, Department of Neurology. So we will go through our usual kind of format, which will be some opening notes and reminders. If this is your first time with us, welcome, and we'll do at least get your information in chat. We've got a great didactic revisiting the topic of diseases causing dementia, masquerading conditions and flags, and then our own Kristen Childress bringing a fantastic case as well. So a couple reminders. If it looks like everyone is accurately named, that is great. And it looks like everyone is muted, which is also great. But please saying your name when you unmute to get to know you. Also, if you're able to turn your video on, that's always appreciated, but understand if you can't. And if there are more than one of you in your location, making sure that everyone's identified in the chat so we keep attendance for CME and other purposes. If you are a University of Washington faculty, staff, or a student, there is a new procedure for CME, for free CME. So we would ask that you send your University of Washington address to that phone number, 833-394-7078. You will get an immediate response identifying you and that you've been registered for this. And then at the end of our session, texting 8574, which is the identifier for this CME event, to that same number. So that's for UW faculty, staff, and students. Anyone want to CME? For everybody else, it's the same process that we've been undertaking where Samantha will track all that through our records and Zoom analytics. All right. Just some reminders about other learning opportunities. So there are the UW Traumatic Brain Injury and Psychiatry and Addictions Echoes, Telebehavioral Health Training Series, telephone consultations, including pain and opiate provider consultation hotline, the telepain series. We'll send out these links as well. And of course, the psychiatry grand rounds, which have wonderful sets of didactics around related and allied topics. All right, a couple reminders. We have done everything we can to protect PHI, and we'll ask the same thing for our discussions, making sure that we're not revealing anything that would identify anyone. All of our sessions are recorded. You can always go back and watch those. And then, of course, we will do a quick 1-minute post-session survey to get your feedback as we continue to try to revise this wonderful series. All right, here's a glimpse of some of our upcoming didactics. We've got Dr. Rubenstein coming up next session, all the way through the end of April, and we are rapidly closing in on didactics for the rest of the calendar year. And really open to your input and feedback. So if there's a topic that you would love to hear about, or if you have a suggestion for a presenter, we would love to hear it. So get in touch with either me or Nancy or Sammy. Happy to have your input there. I want this to be as meaningful as possible. Similarly, we would love to have your cases. It's such a vital piece of this process, and we all learn something from every case. There's no case that's too simple or basic. There's no case that's too difficult, although it feels like that sometimes. But we would love to have your real world examples. All right. We are accredited for CME. That's all to say about that. No disclosures. Here's our team. Here are all of you out in various parts of our great state of Washington. And one of our cherished hub team members, Dr. Demoto Riley, will be taking it away from here, talking about diseases causing dementia, masquerading conditions, and red flags. Thank you, Dr. Demoto Riley, who is also one of our fantastic behavioral neurologists and researchers here at the University of Washington in the Department of Neurology. And I will stop sharing.
Thanks, Chris, and I will share my screen. All right, and hopefully that is the single slide presentation. Great.
Looks good.
Wonderful. Happy 2024. Happy to be kicking this off. And thank you everybody for joining today. Hope everybody's keeping warm. Do feel free to jump in with questions at any point. I'll be giving an overview of diseases causing dementia, masquerading conditions, and red flags. So at the conclusion of this presentation, I hope you will have an increased ability to describe major clinical features of the most common causes of dementia, recognize sensory, medical, and psychiatric conditions that may affect cognition and assessment of cognition, identify atypical clinical features which may warrant further investigation, consider genetic counseling for certain dementia subtypes, and also appreciate diagnostic imaging findings for certain dementia subtypes. When we think about dementia, this is an acquired significant decline in one or more cognitive domain. So this could be brought to your attention by the person themselves, by someone who knows them well, or even by your observation of changes in how they are interacting with you or other people in your clinic. It also needs to be followed by objective findings on cognitive testing, and you'll hear more about dedicated cognitive testing in a future lecture. These impairments in thinking need to be to the degree that it affects a person's ability to maintain their independence in daily functioning. So their compensatory strategies aren't quite working. They need some help from someone else in order to carry out the things that they used to do completely independently. And this cognitive change can't be due to other conditions. So there can't be other medical problems we would point to, delirium, psychosis, or substances. Now, under that umbrella of dementia, I will be talking about these different subtypes of Alzheimer's disease, Lewy body dementia, vascular dementia, and frontotemporal dementia, recognizing also mixed dementia and dementia associated with Parkinson's disease. But to start out with, thinking about what are masquerading conditions, what are rule outs we should be on the lookout for. So first, really getting a sense of whether this person has any hearing loss or vision loss, which is affecting their ability to take in information and to then remember it. So is that affecting their ability to operate as usual in their daily activities? And also, might that affect your ability to accurately assess their cognition? So being on the lookout for that and having a voice amplifier and readers available for vision if necessary. Also getting a sense of what is the language they're most comfortable conversing in. How far did they go in school? How used to are they to testing? Do they have any learning disabilities you should know about? And if they need an interpreter, if you're going to do cognitive testing, having an in-person interpreter is ideal. Metabolic assessment, getting a comprehensive metabolic panel, CBC, assessing for vitamin B12 deficiency, thyroid function, and depending on how much this person has been brought to attention in the medical system, you may want to screen further for diabetes as well. Doing a thorough evaluation of all the medications, over-the-counter supplements that they are taking, thinking about side effects, thinking about polypharmacy, really thinking about anticholinergic side effects. So most commonly looking for oxybutynin, scopolamine, cyclobenzaprine use, tricyclic antidepressants, so amitriptyline, nortriptyline. These could be long-standing medications that as the person is getting older may not be the best for their brain anymore. Also asking about over-the-counter medications, diphenhydramine, doxylamine, being thorough about not just the prescription medications. Are they taking narcotics? Are they taking opiates? Are they taking benzodiazepines? How much are they using? How often do they take sleep medications? And I always make sure to ask, are you taking anything for sleep? Because again, medications that they're taking over the counter or take habitually, sometimes people just don't think about mentioning them, and that may actually be the culprit of their cognitive impairment. Also, very important to think about delirium, including in the inpatient setting, and you'll be hearing a lot about this at the next session of ECHO. Other masquerading conditions we need to think about include obstructive sleep apnea. Untreated sleep apnea can be a cause of cognitive impairment, which also can be reversible. So very important to screen for it and to treat, hopefully if tolerated, and to think of other options if a CPAP machine is not tolerated. Screening for alcohol use, marijuana, other drugs. Also thinking about depression, anxiety, which may not be treated and potentially needs treatment. Sometimes there's also testing anxiety. Sometimes the symptoms of depression, anxiety can also be the leading edge of a dementing illness. So keeping that in mind is also important, and whether this is a change from how the person usually behaves. Other neurologic conditions to keep in mind include normal pressure hydrocephalus, or NPH. So if this person has the triad of cognitive change going along with walking changes and urinary incontinence, may need to think about NPH. Does this person maybe have an undiagnosed seizure disorder? So are their symptoms more episodic? And also thinking about a brain tumor, this image here is just showing that sometimes a meningioma may appear right in the medial temporal. So these are all rule outs that we're considering when we're trying to discern from the person's symptoms whether they may have dementia. Now, when we think about the three Ds, dementia, delirium, depression, all of these conditions can present with memory problems. But when we think about depression, usually the person, if they are able to encode the information well, that storage of information is intact. It's really the recall that is affected. When you think about the pace of the onset of symptoms, delirium stands out as being a more abrupt onset. Then we think about mood disturbance can happen with dementia and delirium, and being disoriented does not typically happen with depression. You can see sleep disturbance with dementia, but definitely with delirium and depression, and those fluctuating symptoms through the day do not typically happen with depression. Dementia, again, we think of this as a gradual process, whereas delirium is quite fast. So not just the onset, but how impaired the person becomes over time. Depression can be variable. And then thinking about somatic complaints does not typically happen with delirium, but can be present with dementia and with depression. And then thinking about apathy as well, may be present with depression, but can be seen with dementia and delirium. So much of this, as you've been hearing, really depends on learning about changes and how this is a change from how the person was typically operating. Hearing from the person who is experiencing these symptoms, and then someone who knows them well. So it could be a family member, it could be a close friend, ideally having a sense of whether this is a change or not. Sometimes it can also be helpful to gather the information separately. It always helps to talk together, but sometimes even providing a way for the close family member or friend to write down some thoughts. Sometimes there are symptoms which come up, which they might not feel comfortable talking about at first altogether. Definitely getting vital signs, especially if the person has not been in the medical system very much. What's their blood pressure, their heart rate, what's their O2 sat. The weight can become a very important vital sign down the road, looking for weight loss, for example, which could be attributed to missing meals. Thinking about neurologic data to collect, maybe just very briefly seeing if you could get a sense of tone. Is there any Parkinsonism? Is there any cogwheeling? Looking at their walking, either as they're going into or out of the exam room, just can give you some thoughts of, is there anything else I should be considering in my differential? The cognitive testing, again, you'll hear about this in a later lecture, but you may also want to consider a little bit of a writing sample can help to look for Parkinsonism, looking for tremor or micrographia in the writing, just a simple sentence. So once you've reviewed all the medications, heard the history, done some cognitive testing, we think about further testing, and brain imaging comes up first. For a structural scan, ideally a non-contrast MRI, preferred if possible over a CT, just because we get a lot more detail of the brain parenchyma. Ideally also would be a coronal orientation. So this is where it looks like the person's looking right out at you. It really gives us the best view of the medial temporal lobe where the hippocampus lies. Also going forward more and more, this susceptibility weighted imaging sequence. That's looking for microhemorrhages. That's becoming more and more as we head into an era of new treatments. Will be popping up more in terms of the reports, and also thinking about the strength of the magnet, especially with detecting those microhemorrhages, which if it's possible to get a 3T magnet scan, that is more sensitive then to picking up those microhemorrhages. For some atypical presentations of dementia, a different type of imaging can be considered functional imaging, and ideally that would be an FDG PET scan. Sometimes we also have the luxury of pursuing neuropsychological assessment, and again, especially for someone who has an atypical presentation, which I'll discuss later, either early onset or non-amnestic, may consider pursuing neuropsychological testing. And then more and more, we are coming into the age of molecular diagnostics, thinking about the role of a lumbar puncture, thinking about an amyloid PET scan, especially for cases which you may be a bit unsure about whether they have Alzheimer's disease contributing to their symptoms. So that brings us to Alzheimer's disease, which is the most common cause of dementia in people over the age of 65. It does have more of female predominance. And the symptom time course is about 7 to 10 years, recognizing that some people can live up to 20 years or more with symptoms. Also recognizing that we know that these brain changes, the disease itself starts many years before the symptom onset. So the actual disease course is much longer than that 7 to 10 years. When we think about Alzheimer's disease, those cardinal features is really that insidious onset, that slow onset, that gradual decline of short-term memory problems, that episodic memory. So those details of events in recent memory. What was eaten for dinner last night? What were those pertinent details of conversation from last week? Those types of short-term memory issues as the cardinal change we look for in Alzheimer's disease. When somebody comes in saying they're concerned about memory problems, it's worth digging a little bit further to say what exactly they're referring to when they say memory problems. Sometimes there can also be word finding problems. So it's not quite memory, but coming up with the word. Also, there can be difficulties with problem solving and reasoning. And we're not just looking for where the problems are, but also looking for what remains preserved. This can help us going forward. You'll hear about this again in a future ECHO presentation about how can we use preserved strengths to accommodate for these vulnerabilities. Procedural memory, for example, typically that should be preserved in early stage Alzheimer's disease. So knowing how to dial a phone, knowing how to ride a bike, knowing how to button up a shirt, those things are typically preserved in mild cognitive impairment and early stage dementia due to Alzheimer's disease, often through much of mid-stage as well. We think also about that age of onset. So the division right now is 65 years old. If your symptom onset is before the age of 65, we think of that as early onset Alzheimer's disease. And we distinguish this in part because people who have early onset Alzheimer's disease, often there can be a more rapid progression. Not always, but we do see this a lot of the time. And also it's important to recognize that people with early onset Alzheimer's disease may present with non-amnestic symptoms. So they don't start with short-term memory loss. Instead, they may have language symptoms at the beginning or more prominent visual symptoms at the beginning. When we think about early onset Alzheimer's disease, sometimes we think about genetic testing. So while it is recognized that late onset sporadic Alzheimer's disease is heritable, it is quite rare overall, no matter the age of onset of Alzheimer's disease, to have a single gene change, an autosomal dominant gene change, as the deterministic single gene change causing this person's Alzheimer's disease. Less than 1% of people with Alzheimer's disease have this autosomal dominant gene change such as presenilin 1 or 2 or APP. In people who carry that type of gene change, usually there's multiple family members, even in their 40s or 50s, who have this history of early onset Alzheimer's disease, as these gene changes are nearly 100% penetrant. But if you have someone who has early onset Alzheimer's disease, and you're thinking about pursuing genetic testing, I would strongly recommend that you work with a genetic counselor, because sometimes the neurogeneticist may recommend or not pursuing the genetic testing, which sometimes can be costly. Also, the genetics team can think with you about how to appropriately counsel someone before they receive the results of the testing, not only the implications for themselves, but what this could mean for other family members. And that neurogenetics team can be a resource going forward for other family members if needed. Now, we are thinking also more and more about apolipoprotein E, this risk allele for late onset Alzheimer's disease. There are 3 different alleles, ApoE 2, 3, and 4. Everybody has 2 of them. And if somebody has 1 or more copies, so 1 or 2 copies of the E4 allele, they would carry an increased risk for developing late onset Alzheimer's disease. However, this is a risk allele. It is not deterministic, unlike those other autosomal dominant gene changes, and its influence varies by population. And there are people who carry even 2 copies of E4 and can live long, healthy lives without cognitive impairment. So the E4 testing is not typically used as part of Alzheimer's diagnostics testing, and when you're trying to figure out, does this person have Alzheimer's disease? However, going forward in this new age of monoclonal antibodies, it will be necessary to look at somebody's E4 status to think about risk assessment if somebody with mild cognitive impairment or mild stage dementia due to Alzheimer's disease is considering treatment with one of these new anti-amyloid monoclonal antibody treatments. We do think about imaging as well with Alzheimer's, and what we're really looking for is hippocampal atrophy and ruling out other structural changes. So you see here on this side, this is this coronal view, so the person's looking right out at you. This is the temporal lobe here, and in the middle part of the temporal lobe are these nice, healthy, plump hippocampi. This person is about the same age, and again, on these coronal scans, you can see that there is some hippocampal atrophy here. So in the right clinical context, if this is a person who has come to you with concerns for progressive short-term memory loss, gradually changing over time, you see changes on the cognitive testing, or you see the appropriate profile on the cognitive testing. If you have this brain scan, you could say, make the diagnosis of cognitive impairment due to Alzheimer's disease. However, you cannot just look at a brain scan in isolation and diagnose someone with dementia. You really need that clinical history of a decline in the person's thinking to the point that they need help from others. So now turning to vascular dementia, which is the second most common cause of dementia. The usual risk factors for vascular disease: diabetes, cigarette smoking, coronary artery disease, hypertension, dyslipidemia, atrial fibrillation. So be thinking that if that's in the person's history. When we think about strokes, there are the large categories of ischemic versus hemorrhagic strokes, large versus small vessel disease, and then we also come to CAA, or cerebral amyloid angiopathy. And for our purposes, if somebody has a big stroke, that's a discrete point in time. And if there's cognitive impairment after that, it's pretty, I'd say it's probably pretty obvious what was the cause of that. When did things start? What is the cause of the person's cognitive impairment? What we need to spend a little bit more time teasing apart is the small vessels. So there can be ischemic small vessel disease. CAA is also an age-related small vessel disease. And this is when there's deposition of amyloid beta in the walls of small cortical vessels, also in the leptomeninges. And this small vessel disease, whether it's ischemic small vessel disease, CAA, is likely relatively common in older adults, especially those with cognitive impairment. CAA does increase the risk of a hemorrhagic stroke, and carrying an E4 allele also increases the risk of having CAA. So when we think about these small vessel disease dementias, the clinical presentation is this subcortical pattern. So there can be reduced processing speed, reduction in working memory, changes in executive functioning, retrieval. So you give somebody a list of words to encode, and then you give them some prompts, and they can actually do better with those prompts than just retrieving it on their own. There can also be apathy, depression, emotional blunting, and bradyphrenia. And here again, this is where imaging comes into play. And with that small vessel cerebrovascular disease, we're looking for these white fluffy spots on FLAIR. What can be tricky is, the radiology read may say normal for age. Sometimes just taking a peek at it and see, oh, this actually, there's a lot of small vessel disease here. I think that is contributing to the person's cognitive impairment. With CAA, this is when we see it on that susceptibility weighted imaging, or SWI. SWI, that sequence is more sensitive than the usual GRE or T2 star. And again, this is where that magnet strength matters. A 3T SWI sequence will will be more sensitive for picking up those microhemorrhages. So you can see here, there's these little black dots. They're right at the gray-white junction. There's a lot of them. And this person even has a small bleed right here. So this confirms the diagnosis of CAA. Do note that those little black dots, they can appear due to other conditions as well. So that's where relying on the interpretation of the scan, is the distribution and location of those dots consistent with CAA, or based on their medical history, could those be fat emboli? Could they be hemorrhagic metastases? Is there a major history of TBI? Those things can also cause these imaging changes. But again, the distribution is often different. Now, Lewy body disease, that's the second most common neurodegenerative dementia. And roughly there is an 8 to 10 year symptom time course. Again, much variability there. Lewy body disease, LBD, is an umbrella term for dementia with Lewy bodies, or DLB, which typically starts with cognitive changes. LBD also covers Parkinson's disease dementia, or PDD, where the person starts by experiencing movement changes. There's sort of this 1-year rule. Did you have cognitive changes first or movement changes in that first year? And that's how things are currently separated into DLB versus PDD. However, people who have been diagnosed with Parkinson's are at higher risk than the general population for developing dementia. And as time goes on, with Parkinson's, there is an increased risk for having PDD. Lewy body disease is much more prevalent in males than in females. And for somebody with Lewy body disease, these core features are of visual hallucinations, which initially can be non-threatening, benign, but often the person they're quite vivid. There can be pronounced fluctuations in the level of alertness, which you may be able to appreciate just by sitting with the person, doing some cognitive testing. The person seems to sometimes be very with you, other times off in their own world. Parkinsonism as well, as opposed to Parkinson's disease, where there may be that unilateral pill-rolling tremor. The Parkinsonism in Lewy body disease is often a bit more subtle. There may be a little bit of tremor on both sides, for example, a little bit of masked faces, a little bit of low volume voice. On the cognitive testing, you're looking for impairments in memory, attention, and visual spatial skills. Other prominent features to be on the lookout for is a history of REM sleep behavior disorder, which can precede the onset of the cognitive symptoms by 2 decades. This does not mean that everybody with REM sleep behavior disorder is destined to go on to develop Lewy body disease, but it is an important factor to take into account when you're asking about the sleep, you're asking about medications, and any chance that somebody is sleeping separately because they were acting out their dreams. So a lot of in the history taking, thinking about sleep history. There can be autonomic dysfunction as well. So constipation can be a major issue in Lewy body disease, also orthostatic hypotension, and people can have an extreme sensitivity to some antipsychotic medications. You'll be hearing about that in a future lecture. So with Lewy body disease, we do not usually think about pursuing genetic testing. We also don't typically pursue specific imaging testing, although it can be helpful. A DAT scan can be helpful if your clinical exam and history isn't confirmatory. Also, ruling out other causes by brain imaging can be helpful. But in the future, considering a skin biopsy may be part of the mix in terms of making the diagnosis of Lewy body disease. Now, frontotemporal dementia, this is the third most common neurodegenerative dementia. So that's after Alzheimer's, then Lewy body, then FTD. In people under the age of 65, FTD is the most common cause of early onset dementia. So somebody under the age of 65, think about early onset Alzheimer's disease, but also be thinking about FTD. There is roughly a 7 to 10 year symptom time course, but again, there is significant variability by the subtype. I'll talk more about that in a moment. And there is a much higher risk of someone having a single gene change as the cause of their disease. And again, these gene changes are highly penetrant. So a person carrying one of these gene changes is highly likely to develop symptoms of FTD during their lifetime. There are three different genes, MAPT, three different main genes, MAPT, progranulin, and C9 open reading frame 72. I call out C9 open reading frame 72 because that is also associated with motor neuron disease, or ALS, and someone can present with ALS or FTD or both. And that if somebody has motor neuron disease as part of their clinical symptoms, there is a much shorter time course, even as short as 2 years. And this is another case where perhaps even more strongly, I would recommend genetic counseling before performing testing, partly because there is a very large range of symptoms that are under the FTD umbrella. So being able to not only pick the appropriate testing, but also to provide appropriate genetic counseling to the person having testing and their family members becomes even more important. Even though there's a higher risk of having a single gene change as the cause of the person's FTD, it still is largely sporadic. This, 30 to 40% may have a single gene change, but the majority of people have a sporadic form of FTD. With the different subtypes of FTD, there's the behavioral variant, and then there are the language variants. And it's roughly a 50-50 split, perhaps a slightly more behavioral variant FTD or BVFTD. Someone with BVFTD can have disinhibition, apathy, loss of sympathy or empathy, these repetitive or compulsive behaviors, even sayings that get said over and over again, dietary changes as well, so much more of a sweet tooth, or suddenly starting smoking or drinking, which is out of character for that person. For the language variants or the primary progressive aphasias, there are two different variants. There's non-fluent variant PPA, which the person has difficulty with motor speech planning. There can also be agrammatism. This is in comparison to semantic variant PPA, where the person has difficulty with word knowledge. So the speech is often very fluent, but vacuous. The meaning is lost. It's almost like a Wernicke's type aphasia. And the semantic variant of primary progressive aphasia can actually have quite a long time course, 2 decades or even more. In FTD, we do rely quite heavily on imaging. It's very important to take the history, but to be without knowing if there's a gene change to say this person has possible FTD versus probable FTD, you need to see either atrophy or hypometabolism in the frontal temporal lobes. So here in this person, this is an axial horizontal slice. There is striking frontal atrophy. And on this medial slice, this sagittal slice, again, this is knife-like gyrite, very, very severe atrophy of the frontal lobes and relative preservation of other parts of the brain. So in summary, on this big table, we have Alzheimer's disease, vascular dementia, dementia with Lewy bodies, and FTD. Alzheimer's is the most common, but what is even more common is to have a mixed dementia, especially as people get older. Very common to see Alzheimer's and vascular disease together. Also very common to see Alzheimer's changes in somebody who has DLB. Also very common to see all three together, Alzheimer's, vascular dementia, and Lewy body disease. We went through the early symptoms of each of these different dementias, and then again thinking about the different parts of the brain. If imaging, if you're looking at imaging, where you'll be looking for the changes. Again, sometimes we can see occipital lobe changes in DLB, but not always. That's at the back of the brain. The course over time, we think of these as being progressive. And then with Lewy body disease, there can be some fluctuations. With FTD, can be a bit faster. With vascular disease, there can be a stepwise progression. And then there's the associated underlying neuropathology. Amyloid and tau for Alzheimer's disease can be hemorrhagic or ischemic for vascular dementia, alpha-synuclein for DLB, and the most common neuropathologies in FTD are tau or TDP-43. So just before we end, thinking about the red flags, things that in your history or during your exam that might prompt further workup. So thinking about somebody who comes in and there are early symptoms, so maybe even before the age of 60, certainly before the age of 55, it would be much less common, and it would deserve further evaluation. If there's an atypical onset or atypical course, so the person doesn't present with progressive short-term memory issues, but instead there's more visual symptoms, more language symptoms, there's a more rapid progression than you are used to seeing, or if there are fluctuations in the person's cognition. Other unusual early neurologic symptoms could be a tremor, the gait changes, coordination issues, or falls. Also, if there happens to be significant muscle atrophy early on, if there are voice changes, so the person's voice sounds nasal or there's a low volume, if they talk about problems with swallowing early on, also if there's urinary incontinence early on. So, for example, that may cause you to think more about normal pressure hydrocephalus. Here you see this person's hands. This is the typical what they call split hand sign in ALS. So if somebody's saying their hands are weak, there's also behavioral changes. And then on exam, you see that atrophy, thinking about FTD ALS. Early neuropsychiatric symptoms, such as hallucinations or delusions, those may point you more towards Lewy body disease, and the behavioral and personality changes may point you towards FTD. So thinking about pursuing a more extensive workup if you hear these unusual symptoms early on or see these changes on your exam. And just to wrap up here, our future resources and references. There are different amplifiers. The Pocket Talker is very popular. The Beers criteria, again, you'll be hearing more about medications in later talks. And these are different scales and screeners for sleep apnea, for alcohol use, for depression, for anxiety. And then finally, thinking about these various associations, which can be helpful diagnostically, but also providing information for patients and families to learn more about these different diseases, and also support. You see there's a hand raised.
And it looks like that question was also asked in the chat, but if you want to unmute and ask, that is just fine, or I can read it for you if you're not pleased to do that.
Yeah, so the question is why Lewy body dementia is so associated with visual hallucinations. So if you were not all through our medical training, but there are other classes of dementia, like even cases in subcortical dementia in which people can have visual hallucinations. So I'm just curious what your perspective is on that, and if it limits the, if I feel like we're focusing a lot on the visual hallucination to diagnose the Lewy body, and then like for instance, subcortical dementia can have visual hallucinations. So why just such an association with the Lewy body, and should we be really focusing on that to make that diagnosis? Or is there other, like, I just want more clarification around that, because it seems kind of untrue to have it be the sole classification, since there are other cases of other dementias having visual hallucinations.
Yes, other dementias, you can definitely experience visual hallucinations in other dementias. But having visual hallucinations, which early on, which are tend to be well-formed and non-threatening, it's not as common in other types of dementia. And so that is why, again, with the diagnostic criteria for early symptoms does point towards Lewy body. Yes, you can see them in other diseases. So that's why you want to make sure, you do the full workup, you rule out other potential causes, and you look for other supporting features when you're making your differential diagnosis. But it's part of the way they come up with a diagnostic criteria is, doing the pathologic analyses and then going back and saying, these were the symptoms that were reported early on, and then we have the pathologic confirmation. So yes, not all visual hallucinations are caused by Lewy body disease, but it is such a striking feature for this disease that I think it is important to first think Lewy body disease when you hear that symptom, while at the same time you're ruling out other causes.
Well, so for instance, I have a woman with Parkinson's disease who had movement disorder prior to having her memory problems, who's now having visual hallucinations. She's, I would say, in the moderate category of dementia. So I'm more inclined to put the label of Parkinson's disease dementia, but based on your description that the visual hallucinations weren't earlier in the time course for her, but would you say that's correct? Or, I mean, it's just kind of.
Well, it sounds like from your description that the person's early symptoms were motor disease. So yes, it sounds like now they have Parkinson's disease, dementia, and as part of their dementia, they are experiencing those visual hallucinations. Not to go too far into the details, but there is actually a lot of movement now in the Parkinson's disease community to redefine some of these diseases, especially now that there's more of an opportunity to identify alpha-synuclein. So all these terminologies may change, and sometimes there is a lot of concern too about how will we talk about this with patients. So I think helping people think about the spectrum of the disease, and also how to make sure they're getting the appropriate treatment and resources for the various symptoms. That may be your best guide. But having Parkinson's disease dementia can include experiencing those visual hallucinations. It falls under that Lewy body disease umbrella.
Excellent. And I see one question from our friend and colleague, Dr. Gomi, also in the chat.
All right, Reza is saying, oh, Reza, do you want to unmute? So in CT or MRI reports, we see white matter changes or encephalopathy, but there's no history of stroke. Do you consider these findings as vascular dementia? Yes, so that's why I was thinking that having MRI can be helpful. And getting a glimpse of the burden of the disease on an MRI can be really helpful. Does it line up with the person's symptoms? So yes, but often there is no history of stroke, or no point in time where there was a big stroke. It's that small vessel disease things. Just the person has lost their edge. Things are just not working quite as well, and yes, that would still be vascular dementia, more of that small vessel disease.
Excellent. All right, Dr. DeMotta-Riley, thank you so much for such a thorough overview. And I know you only hit the highlights on many of these things and could go much deeper into each one of them, but really appreciated your take on all of them and the resources. So I think this will be required viewing for any folks who want to join our community. Thank you for that. All right, well, let's transition to our case. I'm going to go ahead and share my screen one more time. And I am pleased to welcome our fantastic colleague, Dr. Childress, who has graciously offered to provide a case today. We took the liberty of putting together some slides, so I'm happy to drive while you talk through it, if that's okay with you.
That sounds great. I appreciate that, Chris.
Well,
I feel like this case relates so well to the excellent presentation Dr. DeMotta-Riley just gave. This isn't a complicated case in the sense of often we have cases in here that, confound everybody just because, they're difficult, right? There's no straightforward approach. This isn't one of those cases. This, I feel like, really highlights some of the challenges that are more nuanced that we run into in primary care. And so I'm hoping that maybe that'll be a little helpful for some of my primary care colleagues as well. But so I have this lovely 83-year-old patient that I met for the first time last year. She has a history of breast cancer, status post lumpectomy, chemo, and radiation. She started an anastrozole in 2021. She also has a history of hyperlipidemia and recurrent DVT, initially on warfarin, now on Xarelto. Over the last probably couple of years, her family relates that she developed some memory issues, but she was also the full-time caregiver for her significant other. And so it's hard to say how much of that was related to caregiving stress, as well as her cancer diagnosis and treatment. All those things are probably blended together a little bit, but it definitely became significant enough in 2022, towards the end of 2022, that she was seen for this in her previous primary care clinic. At that point, her MMSE was 23 out of 30. Oncology ultimately put her anastrozole on hold because they were afraid that maybe this was contributing to her situation. And really, what the family tells me is that she was not doing very well at home, related to keeping on top of her medications. Her finances were in disarray. Her brother ended up invoking power of attorney to take over her finances. She was missing appointments, kind of that picture that we hear fairly commonly, right? So they were working with her extensively to try and get her into assisted living where she could get more help, and her significant other could as well. And unfortunately, he passed away the day they were supposed to move into assisted living. So then we have this grief factor on top of everything else as she's also changing living situations. And that's about the time that I met her in May of 2023. So she actually has pretty good insight into her short-term memory loss. If you go in and talk to her, she tells you how frustrated she is that she can't remember anything for more than 30 seconds, which might be generous. Actually, her carryover is very, very poor. But in spite of that, she's really active and social. Her only other major complaint is that she has some back pain that's managed fairly well with acetaminophen. She did have a short course of physical therapy for back pain, but I just have to tell you, because this is so fun, physical therapy discharged her within a couple of weeks because she already has her own home exercise program. She does 2 or 3 times a day, which includes doing headstands at 82 or 83. And so physical therapy didn't feel like they could offer her very much more than what she was already doing. She's also very active in walking around the assisted living community. Her past medical history, besides what I've already mentioned, really is very minor. She has a history of osteopenia. She also, I noted a cardiac murmur when I first saw her, and so she's had workup for that. She does have moderate to severe aortic valve stenosis, and cardiology has deferred sending her for a TAVR at this point because she's asymptomatic. So that's something they will follow up on in the future if she becomes more symptomatic, but have decided not to manage right now. Social history, she's not a smoker, never has been. She doesn't drink alcohol or use substances. She was a school teacher. She taught Spanish and music, following a stint in Argentina as a missionary. She's widowed. She has an adult daughter. Her family dynamics are fairly complicated. Her brother in Oregon has power of attorney. Her daughter is local. Because of the dynamics, things like transportation to get to appointments is challenging. As I mentioned, she exercises regularly. She prefers a healthy diet, and she now has a new boyfriend at her assisted living. So that has actually helped her mood and her outlook, I think, quite a bit. When she came to me, she was just on warfarin and supplements. Since that time, we've converted her to Xarelto, so she's not having to get INRs all the time. She's getting acetaminophen for her back. And then I think probably this got converted to a different slide, but I did add escitalopram because initially on testing, she was scoring pretty highly for depression. I didn't escalate her dose past 5 milligrams because she seemed to have a pretty robust response to that. So in her initial cognitive and mood testing, this was her MoCA. She scored 19 out of 30. In the visuospatial executive function, she really had trouble with the line drawing activity, but otherwise you can see did well on the box and on her clock drawing. She did fine with her animals. Really where we see that she had her major struggles was with a delayed recall. She also couldn't count backward, or she couldn't order the second set of numbers there as well. She scored 10 on her geriatric depression screen, which was positive and correlated with her self-report of down mood. On her labs, her CBC, CMP, B12, folate, and thyroid tests were all within normal limits. Her cholesterol was elevated. I was realizing as I was preparing this case that it was something I never really circled back to, in part because when I first took her on, she was still doing her medications herself, even in the assisted living. And that was not going very well. And so I wasn't about to be adding another medication into her regimen at that particular moment in time. But again, is something perhaps worth revisiting. And it's one of my questions today. We were able to get an MRI of her brain, and this was the report. She has no metastatic disease, which of course was a concern given her breast cancer history. She had minimal scattered T2 hyperintense lesions in the white matter and mild volume loss. Unfortunately, there was nothing on the report about the presence or absence of hippocampal atrophy. So this was, and I don't have access to any of the images, so I have no way to go in and look at this myself. As I mentioned, she responded well to escitalopram. Because of where she was scoring on her MoCA, even though that was sort of equivocable for MCI versus dementia, with her significant impairment and ability to manage finances, her meds, those other things, I felt like there was enough substantiation to go ahead and trial donepezil. And unfortunately, she didn't do well on this at all. So staff noticed that she went from being very active in her activities and out every morning for group exercise to self-isolating and being very anxious, actually. At first, we couldn't tell if there were some other dynamics there with her new significant other, but when we hit the 10 milligram dose, it became very apparent. She wouldn't come out for exercise. She would barely come out for anything, and it immediately reversed when the medication was discontinued. To give you some idea, at this point, she's so active in her group activities and group exercise that she actually leads exercise for the entire community most days, which is really exciting. She has her little list and she goes down it for their exercise. So the questions I'm bringing to the group are really, was I doing the right thing in saying that perhaps we could call this dementia? When we look at her MoCA score, it's right at that breakoff point where we could say, well, this sort of falls within mild cognitive impairment. However, she is having impact on her daily activities, like Dr. Demoto-Riley was calling out when we're thinking about the diagnostic criteria for dementia. I'm curious in the Hub team's impression of the MRI and other information and how that weighs into this whole picture and how we might think about, if we're calling this dementia, what kind of dementia. I'll just note too, one, besides the transportation being a limitation for this patient, we also have very limited access to neurologic resources or to neurology resources in our community. So trying to get her an appointment with a neurologist is very, very difficult. I'm curious, given her age and the fact that she really has fairly minimal CVD risk in general, whether or not we think a statin might be beneficial given her cognitive impairment and her overall picture, and then whether or not we think that trying something like ribostigmine instead of donepezil or any other type of therapy might be helpful for this lady. So appreciate insight and other questions about the case.
All right, Kristen, this is a perfect case. It is the real world's kind of primary care oriented, exactly who we love to see. So thank you for bringing it forward. And I am sure our Hub team has both questions and opinions, but I'm going to ask them to hold off for a second while the rest of our community asks any clarifying questions, things you might want to know about this particular case, knowing that it may not be knowable. But what else would you want to know? I have a couple thoughts, but I'm curious who else has some questions. Sylvia.
Thank you for the case. My question on the MOCA, during the immediate recall, so when you initially give her the 5 words to learn, can she learn them all pretty well?
She struggled a little bit.
Okay. And eventually she could record all 5 of them with the repeated attempts?
With repeated attempts, yes.
Okay.
But then could not bring back any of them at all.
Even when you gave her cues?
Correct.
And she had some false positives, meaning she would say, oh, instead of face, it was arm, or it was cotton instead of velvet, or things like that.
Mm-hmm. Yeah. She just really struggled and couldn't bring it back to the words, which is consistent with her carryover in conversation and other items as well.
Makes sense. And did she get chemotherapy for her breast cancer in the past?
She did.
She did. Okay.
Mm-hmm.
Thank you.
Yeah.
Excellent questions. Other clarifying questions? That was one of mine about how she did on the encoding trials in the MOCA.
I have a question about her current living situation. So she lives with in a assisted living, right?
Mm-hmm.
And what you mentioned that she has one daughter and the brother, and she was used to be social. So what are the relationship between her and her daughter, and how much she's involved in her life or kind of decision making?
Yeah, so the brother has POA for finances and healthcare. Her daughter does come to see her mom and is willing to transport her mom when possible to appointments. Her follow through is a little bit hit and miss, so it requires a lot of follow up on our part to get those things done. Some of the dynamics are around the fact that the daughter was using her mom's finances in ways that were not appropriate, and convincing her mom to give her large sums of money. And so and then when the patient's brother got more involved and said, no, your mom needs this money for her care, the daughter quit talking to the uncle, and so they wouldn't communicate about the mom's care needs. And so then, like for me, I would have to communicate to both of them directly in order to facilitate anything. So
You're also moderator here. Okay.
yeah, exactly.
Good questions. Any other kind of things people want to know before we move into maybe answering some of the questions that Kristen's brought forward? Going once, twice. I feel like Karen Clay might have a question about the role of grief and bereavement, but I don't know, I could be wrong.
I don't know that I necessarily have a question about it. You know, she did go through a lot of big changes and a lot of big losses. It sounds like it's a little bit hard to tell, sort of, you know, because she didn't have as much oversight, and then her significant other died. So just sort of thinking about that kind of, you know, potentially complicating, sort of being able to understand what, you know, how much of this is, you know, complex grief. It sounds like a good sign that she's really embraced living in the assisted living community, though. Like if she's seems to be enjoying herself, being active, then I would say that's kind of evidence that that's not as much of a factor.
Yeah, I wonder how many of the other residents are doing headstands now. She's leading exercise. But yeah, hopefully that's supervised. So to your questions though, in terms of, you know, your very first question, can we call this dementia versus MCI? Curious what people think.
I don't necessarily have an opinion, but it's a great, like, this is such a great and common primary care issue, right? Like, how much does the daily function have to change? In what categories? Is it by report, or is it by watching them do something? Is it by what their daughter says, or is it by what the caregiver says in their care situation? So I would love to hear both the answer to this particular question, but also, you know, other advice on that topic.
So before we address that, can I get some more information on the medication problems? You said she's still managing her own medications, but it's sort of difficult. Can you elaborate on that?
Yeah, thank you. So to clarify, she's not managing them anymore. Basically, we had to get a documented track record that wasn't working, and what that looked like is she would miss her medications. I would go in and find that she had her supplements lined up on the counter, and still 2 full pill containers, you know, stocked. It was very hit and miss where she was taking things from, and also her INRs were all over the place week to week, and so I could tell that she was not getting her warfarin consistently.
Yeah, excellent question. I'm also curious, she's not driving, and is she not driving because of sensory or physical issues, or is she not driving because of cognitive issues?
She's not driving because of cognitive issues. Sensory wise, so for example, she still plays the piano. She's still obviously very mobile. So.
Mhm. Yeah, I see some consensus in the chat of this crosses the line into early stage dementia based on her functional impairments with higher level instrumental activities of daily living. Is there anybody that would, you know, consider otherwise? Be a fair consideration.
This is Karen with a question about MCI versus progressing into dementia diagnosis. What's the, how do I put it? I'm sorry, I'm Karen. I'm the caregiver representative on the ECHO dementia. And just thinking about my own husband's case of, yeah, it starts as MCI, becomes dementia. What's the impact of that? For him, it helped us because he was getting his disability insurance, and they needed to see that he was progressing in order to say he wasn't malingering or blah, blah, blah. But, you know, are there downsides of that in terms of if you're pre-Medicare, and now that we don't have pre-existing conditions for health insurance, you know, I think in the past maybe you might want to hold off on calling it dementia or that kind of stuff, or just, you know, the patient having self embarrassment about saying that they have dementia. I'm just curious about what's a trigger for, other than how they're presenting. Is there a downside to calling it dementia now?
It's one of the hardest diagnoses that you have to say out loud, at least, you know, and it never becomes easy to have to say to somebody like, I think this fits dementia. And what I try to do, it's never something anybody wants to hear, I believe, but what I try to do is say, when we say dementia in medical terms, this is different than the word dementia you would use in day-to-day life. Whereas in common language, you may say such and such as dementia, that usually refers to the worst case scenario, somebody in a home doesn't know anybody. We use the term dementia for things that are usually sometimes milder than that. Sometimes it's that, sometimes it's not. And then I always try to follow it up with, there is a lot of stigma, but people can have good quality of life, assuming that we take this seriously, you know. And so it's obviously something that nobody wants to hear based on obviously common knowledge, but that's what I usually try to do to get the person. And then I pause, and some people cry, and some people say just don't grasp it. And so that's why I pause to get them to process this. But you're right, there isn't really a good time to call it. For the prior question, it oftentimes people like this are really, really active and they almost seem normal. They can compensate a lot. This seems pretty clear that she cannot really take care of various instrumental activities of daily living. So it seems like it's mild dementia. But when it's kind of borderline, sometimes she does and sometimes she doesn't. I always ask the question, so if you left her alone for 2 weeks, would she do everything on her own? And how quickly that answer comes, oh no, then you kind of have an idea or an inkling, but it's really hard sometimes. I do agree with all of you.
I'll just say that my own interpretation was exactly what Brock put in chat. That was kind of how I was looking at it personally. That was my rationale.
Yeah, I think we've got pretty uniform agreement. I'm curious, you know, we've got 5 or so minutes from either our community or the hub team. Any comments about the MRI, the question about statins or any other therapies or next steps? What would y'all recommend?
Sorry, what was her LDL? I don't recall.
It's fairly high. Sorry, I don't have it.
I can tell you that. It was 148.
Oh, it was 148. So, I mean, I believe the evidence on statins, and someone can correct me if I'm wrong, is that if somebody is going to be alive for 3 more years, they'll get benefits to it. There's large population health studies in community dwelling older adults who, though she's technically not community dwelling anymore, that their overall benefit, like mortality benefits and also quality of life benefits, like that there's less disability at the end of the person's life if they're on a statin. I don't know about if the evidence is because the person just went to the doctor more and listened to the doctor and that's why they're on the statin, but I thought that study was sort of significant to the people that I would see in my clinic before, at the polyclinic before I started working for PACE. By the way, I work at Providence as well, and the PACE at the PACE site at MLK. And so I would say that she probably would get some benefit out of a statin medication because she seems really active and like she's out in the community and she's going to be living for a significant time period. So if she didn't have any muscle aches or anything, I think there's enough evidence saying that she'd get some benefit out of the medication.
Excellent. I saw Trang, you unmuted. I'm curious what the pharmacist take on this is. Then I see Brock has a hand up also.
Kristen, thank you for a great case. What is her blood pressure? Is it within
Her
the
blood pressure is well controlled without
control.
any medications. She doesn't have any history of coronary artery disease or other risk factors. No diabetes.
Okay, so I'm looking at the clinical the cholesterol clinical practice guidelines from the American College of Cardiology and also the American Heart Association. And this is what it says. It said in adults 75 years and older with an LDL between 70 and 189, initiating a moderate intensity statin may be reasonable. But there's also another one. In adults 75 years and older, it may be reasonable to stop statin therapy when functional decline, physical or cognitive, multi-mobility, frailty, and reduced life expectancy limits the potential benefits of statin therapy. And so I think that kind of fit the patients that we are having. Is that patient's age is 87, right, and has cognitive decline. So even if somebody's on statin, we're gonna stop. It's reasonable to. So I think at this point, I feel like it's not to initiate statin therapy. I do have one more question about the Xarelto, though. Xarelto, rivaroxaban this year in the Beers list, that it has been moved from the use of caution to the potentially inappropriate medications, just because the DOAC has less bleeding risk, which is Eliquis. So if you're thinking about, maybe have better benefits or less side effects for the patient, then I think Eliquis be recommended.
Great, thank you.
About.
Good. And Dr. Gaster?
Yeah, I personally would say that the really, really hard to make a sort of evidence-based case that a statin would help, and but it's also unlikely to hurt, so it's just like not that big a deal. But I wouldn't necessarily go out of my way to start it. To me, like the big thing that I would really be thinking about is a durable power of attorney as backup for the brother. That it's very possible that she's going to outlive her brother, and that she might not want her daughter to be the backup to the brother, and that by that time she's not going to be able to identify who the backup to her brother would be. And so I would really try to have that sort of difficult conversation with her of like, who would she want the backup to be if it's not her daughter. And just to kind of, like everybody's sort of thinking about lecanemab now, and just to sort of point out that she would not be a candidate for lecanemab because of her DOAC therapy.
Thank you so much. I appreciate all those thoughts.
Excellent points. Any other last minute? I realize we're at time, but I don't want to cheat Kristen out of any recommendations. Sylvia?
Yeah, so regarding the donepezil question, in general, Alzheimer's people either don't change when you started, or sometimes they feel a little bit sharper. But I have seen anxiety with donepezil, even in Alzheimer's patients. I would say the important thing is clarifying the diagnosis. Sometimes there can be late effects of chemotherapy that can cause forms of dementia, but those usually stay static. They don't progress fast. And so follow-up in time may be helpful. Getting those MRI images to see how much hippocampal atrophy there is. Spinal tap is complicated in this case because you would need to stop the Xarelto, which can be done, if we're pushed against the wall. In some Alzheimer's patients that get anxiety with donepezil, I sometimes give rivastigmine capsules because they're lower dose and they're more gentle release. And sometimes they cause less of that peak that then causes anxiety. May or may not work.
Great, thank you so much.
Very good. Yeah, thank you for the reminder too about time. So her mini mental was a 23 out of 30 in November of 2022, and the crosswalk between mini mental and MoCA 19 is not very different than a 23. So that you've got 2 points of data. So now in 6 months or so, you'll have a third potentially. So very good. All right, I'm going to share my screen one last time because I want to acknowledge that our next session will be Friday, January 26th with the wonderful Dr. Carrie Rubenstein talking about dementia, comorbidities, and delirium risk prevention through team management. So hope we will see you back for that. Thank you all for joining us afternoon.